the UHC in the few coming months. Whether NHIF is going to be the vehicle through which this program is going to be launched. Is it going to be affordable? Is it going to cater for the cost? Look at what is coming out in the few days where NHIF is saying cannot pay for surgical services, can't pay for dialysis services. So it tells you the way the fund is constructed, there's a problem and they need to actually come to the ground and talk to the key stakeholders.
Yeah. Dr. Ngani, do you think this is the solution, the NHIF bill, amendment bill that was just done?
Well, the amendment bill has its good sides and some sides that are not good. I think when you look at what's going on in terms of NHIF, I'd take us back significantly, to the last decade. There was a time NHIF was spending as much as 40% of what it was collecting in administration costs. They made some progress. Around 2017, I think, would be the best year for NHIF, Trevor, because in this year, NHIF introduced the surgical packages. There were discussions around covering ICU to some degree. We had some discussions around special laboratory tests that were to be done. In that year, NHIF was covering 100% of the cost of care for any child who had a cardiac issue or any adult who had a cardiac issue. And you could see that when these packages were being rolled out, the surgical package, when it was rolled out, when we spoke about dialysis being rolled out, then NHIF made sense. And people were willingly now getting into NHIF because when you paid for NHIF, NHIF would take care of you. The discussions we're having now of rolling back benefits from NHIF, these discussions are probably discussions that shouldn't be had. We should be talking about extending benefit to areas that are catastrophic in nature. I'm talking about ICU, talking about anything that would put a family in poverty. That is what NHIF should be covering. The second question about NHIF is where should you access this service? And many times I hear these discussions around only public hospitals. And that will be good if every single service was in those public hospitals at the level that is responsive. I had my uncle whom we had to take to a private facility for radiotherapy because the kind of radiotherapy he was having has extensive side effects. And even where he had it, he almost died. But you see, this is the most effective machine available. It's not by choice. It is because this is what was available. But I want to take us back to the cost of healthcare in general in Kenya. And over the last year, it's been quite evident that in Kenya, we need to protect ourselves against high costs. There are significant middlemen in the process, and hospitals are not really at the end of this. They're down in that chain. A good example, we recently spoke about vaccination in COVID-19 vaccination. One vaccine was supposed to be sold commercially. We know that the vaccine costs 1,000 shillings in the market. The person who invented the vaccine says, give me 1,000 shillings. It gets to Kenya, to the hospital, at 7,000 shillings. And this is the symptom that, it shows you what happens across the whole chain, whether it's medication, whether it's machines. The machines we use in the public sector, in the health sector, these machines, the costs are too high, compared to what the actual costs are. And unless we begin to pay attention to what drives up costs and work on those fundamentally, we'll not make tremendous progress. I remember one time talking to my boss where I work and telling him, these monitors we have, the quality is not good enough, we need to remove them. And just 4 monitors, you're spending over 2 million shillings. Now, these differences would result in differences in prices. If a facility focuses on quality care, in Kenya now, where the costs are as they are, then this cost will always be high.
And what drives up the cost? Is it human factors, or is this reality on the ground, or is it just deliberate to steal from Kenya?
There are many factors, Trevor, and I'll tell you without hesitation that right now, Kenya is a middleman economy. People who don't produce but actually look at where the item is, they are the ones who make the biggest profit. And I've given you the example of the vaccine that was meant to be sold commercially. The vaccine is 1,000 shillings in the free market. In Kenya, it was getting to hospitals at about 6,000, 7,000 shillings. The middleman is making 6 times more than the inventor of the vaccine. And the same thing goes, any machine you're buying, be it an MRI or a CT scan, the actual cost is about double because of millions of taxes. Medication, anything that we get here today, Trevor, the cost is multiple times. The families that have suffered, there's this drug now that's used for COVID-19. It's called tocilizumab. The cost when COVID is not raging is 92,000, which is still very high. That's one dose. And when there's a surge, within 1 week, the price rises from 92,000 to 180,000. Talk to the families. But these are stories that we have to pick as society and understand that this has to be done. We have to do something about it. We talk about for example, the access to basic sort of services that will be available in the public sector. But these things for the last 10 years, we've spoken about the availability of these services. They're not there. So a family that cannot afford has to go to a private hospital, which they cannot afford as well because of broken systems. So these are solutions that exist today, and we can actually pay attention to them and make a difference. But that initiative has to start from somewhere.
Yeah, and Dr. Davji, are you saying as KMPDU, your hands are tied on this? There's no way you can protect, even help Kenyans in any way to deal with the cost of healthcare in general?
Generally, what drives the cost of healthcare in this country is the failure of the government to actually invest in the healthcare. Yeah. And that makes it impossible for people to access the services that they may need. If you look at the Constitution, Article 43, the right to healthcare, it talks about the accessibility of healthcare. So if a person, for example, the last statistics that was done by Infotrack between May and August, it showed that 71% of Kenyans will otherwise always go to public facilities. But then when they go to the public facility, 54% will leave there unsatisfied. Number one, they're not satisfied because there are no medical personnel. There are no healthcare workers that have been employed in those hospitals. So they will go and not get services. And if there are doctors, there are a few of them there, it will take the common wananchi 8 to 12 hours to get services in the public hospitals. And then the second thing, once they get the services there will be no drugs. So still they will have the prescriptions to go buy the drugs outside, or they will be told to go and get diagnosis outside. So that will essentially drive the cost of healthcare in the country. But if the government was investing enough in the public healthcare as it is needed and it ought to be, then they will employ a higher number of doctors and other healthcare workers to offer the services in the public facilities. They will offer the best infrastructures so that there could be diagnoses, there are drugs, and things can be put done in the public sector. Yeah. But when that fails, then it forces a bigger majority now to go to the private sector, of which always in the private sector, there will always be that demand which supersedes the supply that is in the market. That in many circumstances affects the costs. Yeah. Yes.
But there are also many doctors who are accused of running their own parallel businesses. So they're in the public sector, but they're also in the private sector. So when you get to the public sector, they refer you to their own institution or organization, which is now private. Not necessarily because they couldn't offer the services here. It's just that in their private capacity, it is more expensive and more lucrative.
This is something that has been, is a rumor that is said out a lot. Yeah. But when you look at the population of doctors to patients in this country is 1 to 16,000. And ideally, we have a lot, or a big number of doctors for the last 5 years that are not being employed. So the country has been churning about 700 every year with limited number being employed. Yeah. So ideally, there is no possibility that we'll have doctors in the public hospitals who work fully and at the same time operating the private sectors. So that idea, when you come to the ground, is very different with what people are actually saying.
So you're saying this is not happening?
Allow me just to respond to this, because exactly 10 years ago, I was sitting in Citizen Studio as the chairman of the Doctors Union having this discussion, and it's a bit unfortunate that for 10 years we've been sharing ideas and this hasn't really caught on, because all we have to do is perhaps listen and do things slightly differently. And the health system is broken. And many, many times, this brokenness of the system is blamed on the healthcare workers. And it seems as if this is a health worker problem. And over and over again, I know I've personally said this, it is not a health worker problem, it's a system problem. If we address the systems that underlie this brokenness, then we'll make some progress. And every so often, the politicians are very happy to get away with lack of investment in healthcare because the public and the media and everyone else would popularly say, you know, it's the doctors who are not making this happen. I'll tell you, I've never owned a private facility my whole life. And yes, there are doctors who are unscrupulous. And I think Dr. Devji, Dr. Weri, we know these discussions have been, and we've actually internally had these conversations around trying to weed and clean our system, make sure that anybody who's employed in the public sector gives the hours that are needed. This is there. But that is not the main reason why the health system is broken. You see, back in 2011, 80% of doctors were leaving the public sector within 3 years. You see, nobody cared about that because the people who were being affected were the mwananchi down there who has no power, and the ones who are supposed to make the decisions can go to any private hospital, they can go to any country they want at taxpayers' expense. And the same thing hasn't really changed over 10 years despite, you know, all we have to do is make the public sector work. And we've seen snippets of this possibility. Look at NMS, barely just a very young organization, and you can already see some progress being made. What is different within NMS that is not present in every single county? And we are saying that there should be a facility that is responsive within a certain distance to anybody, whether you live in Turkana, whether you live in Migori, whether you live in Mombasa. Responsiveness means that hospital is a facility that exists. It has equipment, it has medication, it has doctors, it has everything. And when that is present, and NHIF is covering all these costs within this public facility, then let us discuss the issue around these healthcare workers whom you are saying, for example, are doing ABCDE. I'll tell you, the equipment in facilities, the services are not there 90% because the items are broken or they're not there, or the supplies are not provided.
Yeah.
And one of the most painful ones is you see a very big equipment that private hospitals would like to have. It's sitting in a store somewhere because the personnel for it is not there. And the reagents to make that machine work have not been bought for 2 years plus. That's the reality. It is not that someone went and turned off a button. No.
Yeah. I see you agreeing with that. You're saying this is also a system issue. It's not a personnel issue at all. It
is entirely, to get more than 70%, a system issue. Yeah. And that's why you realize that when, for example, you go to all these particular county facilities, we had cases in Laikipia where the patient died at the emergency unit, and the county government was accusing the laboratory technicians for that particular purpose. And ideally, that was happening because all the consultants in that county have not been at work for the last 2 years. We have situations in Kitui where the county needs specialists to be offering services in the county. But the county is recalling the doctors who otherwise ought to specialize and come back and offer services in that particular county. We have situations whereby doctors are offering services and they're actually at work, but there are no equipment for them to work effectively in those particular places. So that's one of the major issues. Number two, the other thing that is very greatly affecting healthcare is the shortage of the personnel.
Yeah.
It has been, we've been able to go on strikes over this. Last year, December, we've been agitating for that to be sorted. But I will tell you that as long as the governors, the president and the people in the cabinets, the MCAs have the hefty packages in the insurances and are able to access healthcare outside the country, it will be difficult to have them invest effectively in the public healthcare. Yeah. Recently, we saw with this ravaging COVID, the governors who actually ought to be building or rather investing in the healthcare in their counties, when they get COVID, they have to be transferred to the public hospitals like Nairobi hospitals and like Aga Khan and even out of the country. So when that doesn't change, it is very difficult for them to invest in the healthcare for those particular counties. Okay. So the other thing that I'm sure affects is that most of the politicians of this country are also the businessmen. So they will always want the public to fail so that the hospitals or the private sectors that they own actually thrives. Okay. We've seen that in the health committee, whereby the person a member of the health committee owns one of the biggest hospitals in his constituency. So most of the times, the bills that they will put forth will actually to make them thrive, not to make the public thrive. Okay. Yes.
And Dr. Were, this is what devolution was meant to address. 2 questions for you was, did we make a mistake? Was healthcare supposed to be devolved? Has that worked? And what would it take for UHC to succeed? We've seen a pilot in Isiolo, Machakos. What would it really take for it to succeed?
Yeah, Trevor, just before I get to your question, there's the issue of the cost of healthcare. Yeah. And I think there's an important point about taxation. The other day when you're talking about fuel, everyone was out crying, but I think this is something that we have talked about as an association, where the government really needs to look at the taxation of medical equipment and drugs. It's very high, and that leads to the high cost of healthcare that we are leading. And that actually translates directly to the high hospitality costs that we see in most of our institutions. Yeah. The other thing is the cost of just doing business. Other than what Dr. Davji has mentioned on the issue of our health facilities being led by business people, vis-a-vis being led by professionals. So they'll always put the money before the delivery of service. And this is something that we have talked about even in the recent amendment of the health bills. You are seeing the business interest taking the day, where they want to take the governance of the health institutions away from the health professionals to the business people and to the politicians. And a good example Dr. Ngani has given. Yeah. If you look at NMS, it's because Dr. Omoluga is there. And you can see the strides being made in Nairobi County. Look at Makueni. We always talk about Makueni. That was a county whose health department was led by 2 doctors, that's Dr. Mulo and Dr. Kibwana. So if we do not address the issue of the governance in the health sector and the high cost of taxation, then we'll continue having these high costs being levied to the common mwananchi. On the issue of the UHC, what does it take for it to succeed? I'm sure if you're able to access the report of the pilot that was done, it was a very disastrous outcome in Isiolo, in Kisumu, and we didn't learn from that. We didn't listen to the professional voice in terms of how do we move forward in terms of ensuring that we have a system that works for mwananchi. And the issue will come here from funding. How is this going to be funded? We've always said we rather do a health tax rather than the kind of funding that they're proposing to run UHC through NHIF. And there's also the bigger issue of accountability and corruption in the health sector. If we do not have a body that is accountable, and this is what you're seeing actually being done through this NHIF bill, where they're removing the service providers and putting government to represent government. And this, I mean, you put a body like KHPOA in place of Kenya Medical Association in that place. What are you hiding? And you see that is a conflict. You can't put a government body that takes direct instruction from the minister to represent healthcare workers. So as the bill has been put forward, there's no representation, there's no accountability, and the same problems. And the other day, the CEO was on record saying they lose almost 10 billion through corruption. And then you're removing the accountability aspect and the oversight aspect from the service providers. So there's no way you are going to convince us that then NHIF as a vehicle to drive HC is going to succeed.
So devolving healthcare, was that a good idea, or should you have left it in the central government? I
think devolution has brought services closer to mwananchi. And many people, if you move around the country, you'll find that people no longer have to travel to Nairobi to access some service. But the way it was done has always been a problem. It was devolved so fast. They didn't put structures in place. They didn't train managers. And then all of a sudden, you're being told to manage such an important critical service like devolution in the counties. And that challenge, together with the devolution of corruption in those counties, is a problem. And of course, the bigger issue that they've never addressed, you cannot want to provide health service without healthcare workers, without professionals being there to provide that particular service.
Davji, I'll come back to you on this issue. We've seen hospitals charging patients upfront. You want to admit someone, you pay up before they even admit your patient. And they don't care whether the patient is going to die. You have to bring up that money. Is that fair? And is there a way Kenyans can be cushioned from that, from the KMPDU perspective?
You know, in the right to health care and the Article 43 of the Constitutions, we have that everybody has access to emergency health services. And I believe that with the emergency health services, if you go to any hospital, regardless whether it's public or private, you need to access these these emergency services. But ideally, if government invests adequately in the public health sector, we have grants from government to level 6 hospitals, to level 5 hospitals, to level 4s and level 3s. We have the county governments that also funds these particular hospitals. So if you go to any public hospitals, ideally you do not need to deposit any funds before you get services. This only happens in private hospitals when they do not want to have, to actually prove ability to pay and you have admissions. But ideally, if the public hospitals are working and public healthcare is in operation, then we will not need that excess of need to have a deposit in the private facilities to get admissions.
Dr. Ngani, is that, from your perspective, and I know you're a critical care doctor, is that fair?
Fortunately, I've had the chance to work in all the facilities I work at, including the one where I work now. If you have a real emergency, you're going to be attended to first before you have to make payment. Of course, emergency payment, treatment doesn't mean that it's free. It just means that you'll get your treatment, then you'll pay for it later. But where I work precisely right now, actually we had RFH Healthcare, we had a very good, ambitious plan to do away with that kind of discussion of making a deposit. And people would come in and all you have to do is tell us you're going to pay and we'll trust you. Because we were sort of living in this utopian view that, we can make, this space a bit better.
Yeah.
And Trevor, I'll tell you it was painful. Because everyone would make the commitment that we're going to pay. But as treatment goes, no money comes in. And you see, for private facilities, it's what you collect that allows you to pay for services. And if you are trying to maintain level care at a certain level, then at some point you have to be realistic about what you're doing. Because if you do not collect, you cannot pay your staff, you cannot buy supplies, and it becomes extremely difficult. And I'll tell you, there are some serious bans that my board actually went through by this, this ambitious project to allow for just verbal commitments.
Yeah.
And it goes down to our fabric as a society. We have to place honor at a good place. If I say I'm going to do something, let me do it. If I say that I'm giving commitment to make payment, at the end of this service, I will give that, I'll make that payment. But you'll see that at the time now of payment, it becomes friction. It becomes an issue, it becomes a back and forth.
Yeah.
And even families that very well can pay because they see the cars they're parking out there. Because the service has been given, they're willing to make those payments. So if you ever achieve a balance that makes this care effective and makes the word that is given honored, I think we'll be in a better place. This discussion, yes, I see a lot of hospitals being looked at, but we have to look at ourselves as a society. Are we honorable people? Are we trustworthy people? Can we be trusted to, make our commitments? I remember one instance where a family that was making hundreds of thousands of shillings in a month, making a commitment to pay for a bill of about 400,000 shillings, they want to pay 20,000 every month. Without interest for a very long time. Those become very difficult conversations for hospitals that also have commitments to meet.
Yeah, isn't this what UHC was meant to really address? What would it take for it to succeed from a doctor's perspective?
Mm-hmm. So the concept of UHC is to understand that healthcare is a system. And so just to say that we are going to allocate some funds in NHIF and we are going to give free service, that sounds very nice. But what is this free service? You're talking about UHC at a time when, as a mother, you have to come with your own basin, you have to come with your own slippers, you have to come with your own medicine. And if you need the most basic test, it's not available in the facility because the machine is either broken down, or it's not been bought, or the people who can operate have not been there. So the starting point of designing a UHC program is to make sure that there's a responsive facility that is able to meet the needs of the mwananchi. So accessibility to healthcare has two components, Trevor. The first component is availability of that service. The second is financial access. And even if you're to make money available into that space, but the service is not there, it doesn't make a lot of sense. Even then, when you talk about making these services available at 100 shillings, say, per month, is that realistic? At the cost at which we are, even the tax alone on the medication, does it make sense that you can expect to deliver service within that cost? So it's a question of bringing together all the resources and planning it appropriately. I think the planning around it was not perfect. And I know people will get offended when we say this, but the reality is, when you look at the result of the UHC pilots, it tells you something was wrong at the inception. And we have to go back and actually, as Dr. Were says, look at the system and say, what can we do to make sure that all these components are there? And it's not rocket science, it's not too difficult. It can be done. And the examples of working systems. Yeah. One of the things, you look at some of the middle-level private hospitals now that are run by private individuals. They've built hospitals at work. Yeah. What is it that a single individual can do that government cannot do in its own entirety? And the element of corruption remains true. We'll buy in the public sector something that the actual cost about 10% what a private person would buy that item for. So if we are honest with ourselves and address these fundamental breakages, these gaps that we've lived with for the longest time, we may begin to make progress.
Okay. Dr. Were, what would be the best way of dealing with this issue? And we had talked about it earlier on in terms of patients being detained in hospitals over bills and all that. Yeah. What would be the best way?
I think, Trevor, the best way is having each and every Kenyan insured, whether in the public sector or in the private sector. So that you have, because all of us, even when practice, we see patients who come and they're really suffering because they're not able to raise that money. Yeah. But I think a good step, as you've seen, and that's one of the positive things that's coming up from this NHIF bill, is that now each and every Kenyan must be insured. So once we have the insurance and it's working properly, then we don't need to come and speak about this issue of being detained in the institutions. But also, the government has to play its role, especially for the indigents. These are people who are not able to actually pay. It has to cushion these individuals, and these are mostly in the informal sector. And this will enable this group of people access service, even emergency care. Trevor, to shock you, since the Constitution was passed and say everyone has a right to access to emergency care, up to now we don't have legislation that says who's going to pay for that provision of emergency care services by the private sector. And you see, that doesn't work. And you see, I think the ultimate solution to this is the government plays its role, and also we have every individual in this country being insured to access these health services.
Okay. Let me see, there's a lot of feedback coming in here. Abdirahman Mohammed Ali says health is essential. When we are sick, the consequences extend beyond personal, affecting families, the economy, and the well-being of our nation. Who makes healthcare expensive? I blame the doctors who open private clinics and make public facilities look bad. No patriotism at all.
Yes, let me speak to that person, and I fully understand where he's coming from.
Yeah.
And you see, this is the thing of, at some point, someone comes up with the narrative and says that all these breakages, it's not because there are no doctors, it's not because there's no equipment, it's not because the government hasn't bought supplies, it's because doctors are siphoning to private hospitals. And it sounds very appealing and romantic, yet that's the wrong thing. And that is costing lives. And for as long as you're blaming the wrong person, the real culprit in this process will never take responsibility. Because they'll come to you election year and tell you that we are going to fight the doctors.
Yeah.
You know, and it looks like, and year after year after year, nothing changes. If this were the problem, don't you imagine that even some of those doctors have become old and even died in the 50 years since independence? Why is it that the problem persists? Yeah. The problem, ladies and gentlemen, every single Kenyan listening to me out there, is because we have not invested in healthcare as we should. We've said this for 10 years plus. Please hear me. We've tried the blaming the doctors part. It hasn't worked. Today I'm asking us, let's try and listen to this doctor telling us something different. My people, I'm personally passionate about improving healthcare provision. And these questions you're asking, how to make healthcare affordable, the solution lies in one thing: make the public health system work effectively. There is no reason in the world why we cannot have the best institutions in this country being public institutions. Look at dialysis right now. Moi Teaching and Referral Hospital is the absolute best facility in the country in terms of numbers of dialysis cases, and even in transplant, of kidney transplant, the best compared to all facilities in this country. If that can work in that system, what have they done that cannot be done anywhere else? And unless we understand what it takes to build a system, we will not make that progress. And it is not these healthcare workers. If I'm asking you, listen to me now, let us actually put in the resources in those facilities. Let us hold the governors and the MCAs accountable. Let them tell us, how much have you invested in terms of buying these supplies and this equipment? How many health workers do you have? How many facilities are working? I was in a facility somewhere that has not transfused a patient in the last 2 years. I had a patient with HB of 3, and we had to move the patient kilometers away to go and get a blood transfusion, and my queue, they were sent home 2 days later, and they eventually died. I mean, that level of care is not acceptable. And I'm not talking about ICU care yet, because that is now my area of expertise. ICU care, people are going to private hospitals, not because they have all the money to spend, but because the system is just not working in those institutions. So I'd really urge us, Mwananchi, when you listen, I know that some experts in healthcare have told you it's the healthcare worker. I'm telling you that expert doesn't know what they're talking about. They probably dropped biology a long time ago. They're probably an expert in something else, probably, but they do not understand healthcare. And if they did understand, they will tell you it is not the healthcare worker, it's because the system hasn't been put in place to make that system work.
Right. I'll give you all a chance to respond to Abdirahman Mohammed.
Yeah. I think in reality, the person that is, I suppose, that has not really understood the way the public healthcare has been placed by the government. If you look into some particular counties, you realize a sub-county which has even 4 sub-county, or there were 4 hospitals, has only 1 or 2 doctors. So in all the facilities, they can't get services from doctors. They get services from others, but not from doctors. Then you realize that the whole country, in the last 5 years, in employment of healthcare workers, Kenya as it is, we've employed less than 500 doctors, while we have, I think, more than 2,500 who have graduated from the universities. So there's no way you'll go to any facility, public, and expect to get services when that shortage is glaring. when there's no equipment, when there are no drugs in those facilities. We have really specialized as a country in building infrastructures. And I was saying in the last 1 year, those particular infrastructures, as a result of COVID, have mostly been used to transfer the people who have actually died with deaths which otherwise would have been prevented if we had invested more in the healthcare. You realize we are in a country where security in itself, there's a lot of investment in security to the point that the ratio of police officers to the Kenyans actually has been, as per the UN requirement, has been reached. But when you look for the healthcare workers, for the doctors, 10 years down, we're still 1 to 16,000. When you look at the budgeting to healthcare, which was at budget declarations of 2001, Kenya being one of the signatories to that, they say that there will be 15%. Up to date, we are almost at about 7%. Even during the COVID, with the demands in the healthcare that has been there, there's no further investment that has been done to improve healthcare. Only South Africa and Rwanda have at least reached that 15%. And you can see the difference in the healthcare in those particular countries. So ideally, we need as a country to put healthcare as an agenda of the politics. Ask the politicians, the governors who will be asking for the votes, what have you done to your people? There's no need to be a governor for 5 years, watch your people dying and not getting better health services, and then go building PR against the doctors. That has been happening. Yeah. There's need to each wananchi to ask the governors, what have you done? Because when you go to those facilities, you vote for these particular leaders so that you get the services there. So that's something that we need to bring down so that when we go to vote, we understand that this person has failed us in healthcare. I want to give you a good example of a county that a bit of healthcare has actually worked. That is Nakuru County. Yeah. In 2014, there is a hospital health management bill that ensured that every funds collected in every hospital in Nakuru remain in that facility. And that has made it different from any other county in the country, to the point that even the collections in the hospitals in the county in the previous year or the previous quarter was even more than in Nairobi County. So that's one county that actually worked in that regard. Yeah. You can see in Nairobi County or in NMS, we had the Governor Sonko, we had Governor Kidero. What happened in those particular years that were in office? There was a deplorable state of healthcare. When you have Dr. Luga, for the one period that has been in office, I think through the office of the president, we have seen tremendous impact in healthcare by not only building infrastructures, but also employing the healthcare workers who need to offer the services. Yeah. So ideally, it shows that if the governors in different counties, if the leaders in different constituencies, in different places, can put healthcare as one of the greatest agenda, then we can have an improved service provision to every Kenyan. All right.
Yes. Dr. Were, you wanted to respond to Abdulrahman?
Yes, I wanted to respond to Abdulrahman. I think this narrative has been going on for a very long time, where there is a deliberate attempt to try demonize, especially the doctor, the medical doctor, in terms of the challenges that we do face in our healthcare system. Yeah. But Trevor, even if you look now, we're in the period of campaigns. Have you had any politician who has actually sat down with the professionals to have this conversation on how the public can be able to access affordable healthcare services? None of them is doing that. And you see, there is where the problem lies. Because when you have the same politician owning the hospital, he'll want to make, as a business person now, he'll want to make the most profits without really taking into account the cost of healthcare. So doctors don't actually, are not the ones who actually overcharge. If you look, the other day we issued a statement as KMA, where we said actually, according to a survey, between 10 and 15% of the total bill. Yeah, if you look at that bill, the 1.4 million for the patient who had been detained in Eagle, if you break it down, you'll find that less than 20% of the cost there goes to the healthcare professional. The rest of the cost is because of the cost of doing business in the health sector, the middlemen, as Dr. Ngani has mentioned, and the political interference. Those are the issues that are making the cost of providing such an essential service to a citizen like Abdulrahman being out of reach.
Yeah. Yeah. All right. We have to take a quick break here. When we come back, I see some feedback as well. I'll pose the questions to the doctors, and then we'll talk about the ICU facility. And Dr. Ngani is the one specialist in that region. We'll find out from him what the state is looking like right now and what more should be done. All right. See you in just a bit.